Okay. Once again, good afternoon and welcome everyone. Thank you for joining us today. Before we get started, there are a few housekeeping items that I would like to mention. The slides and recording from today's webinar will be made available and sent to participants. You may enable or disable the closed captioning by going to your main Zoom toolbar and click Show Captions. If you experience any technical difficulties, please notify me, Patrick, in the Q&A section. Questions can be submitted into the Q&A window at any time and will be addressed upon completion of the presentation. With that said, I'll now hand things over to Sari Schumann to get us started.
Great. Thank you so much, Patrick. And thank you everyone for joining us today for the National Alzheimer's and Dementia Resource Center webinar, Expanding the Reach of Dementia Programs, Making a Plan and Pivoting as you Learn Through Implementation. The National Alzheimer's and Dementia Resource Center webinar series is supported by the Administration for Community Living. And before we start, Chris Stockton from the Administration for Community Living will give us a brief welcome. Chris?
Afternoon, everybody. I'd like to thank Susan and Todd for presenting on this topic, as well as thank everyone for taking time out of your busy schedules and to attend this presentation webinar to learn more about this topic. Thank you. And Sari, if you could pick it up from there.
Sure. Thanks, Chris. So as you heard, today's presenters are Todd Honeycutt and Susan Sprague. Todd Honeycutt has been working with aging and in-home services for nearly 10 years. Serving as the Family Caregiver Program Manager, Todd continually advances the department to include both service delivery and access to caregivers. Todd is the Program Manager for the Hospital to Home Alzheimer's Disease Programs Initiative Grant and the Site Coordinator for the Aging Brain Care Community Program. We also have today Susan Sprague, who over the past 18 years has worked at an Aging Disability Resource Center as the Director of Long-Term Service and Supports with a managed care company, and currently is Vice President of Expansion and the Administrator of Home Health at OCCK Inc. in Kansas. Her work with caregivers and people living with dementia began during her years at the ADRC, and this focus has continued at OCCK through partnership with the Alzheimer's Disease Research Center at Kansas University, rural health professionals, and participation in the ACL and CMS initiatives and local Kansas partnerships. At this time, I will turn the presentation over to Todd Honeycutt to begin. Todd?
Thanks, Sari. I'm Todd Honeycutt. As Sari said, I am the Family Caregiver Program Manager for Aging and In-Home Services, and I was given the opportunity to work with this ADPI grant, and I'm looking forward to sharing some information with you. Project support. The project was supported through ACL, providing 100% of the funding. And thank you to Sari, Chris, and Aaron for supporting us through the last several years as we ventured into the program. Aging and In-Home Services is a AAA, an area agency on aging. There's 16 AAAs in Indiana, and our AAA services the 9 northeastern counties in Indiana. We border Michigan and Ohio. Aging and In-Home Services provides services such as case management, home delivered meals, information and assistance, our family caregiver services, support groups, and a PACE program as well. The Hospital to Home program is a program that's a care transitions type program. It's a 30-day intensive program that was dedicated to helping individuals with dementia and intellectual developmental disabilities, helping this population reduce hospital readmissions and continue to remain safely at the home. Support is provided in the program by a care coach and a respite coach as often as needed using the Benjamin Rose Institute Care Consultation Program. Our care coach has at least 1 telephone contact per week. We use that telephone contact to evaluate problem areas, needs, assist with person-centered care planning. We discuss their health conditions, what led them into the hospital to begin with, their past hospitalization history, as it's usually pretty lengthy. We help them manage those symptoms that brought them into the hospital a little bit better. And we, at the same time, are assessing caregiver stress and strategies to reduce their burden, because as we all know, the better equipped and the better that the caregiver is doing, the better services that their loved one, the person living or people living with dementia will be provided. So during that program, during the 30-day intensive services, we are also talking to them about long-term services. So we know that, the 30 days is going to run by really quick. We also know that dementia doesn't run by really quick. So we know that there's, several years sometimes after we complete the program that person living with dementia is going to need ongoing services. So we're talking to them about Medicaid waiver services, home delivered meals, ongoing support groups, those types of things. We also were able to provide some services on education and dementia and intellectual and developmental disabilities as needed. Fort Wayne, Indiana is a city of about 350,000. We are the second largest city in Indiana. We have two main hospital providers in Fort Wayne, and one of those providers was a hospital that we were banking on and we were working with hard to get referrals from. We also have 10 rural counties that we worked with. So 2 of those counties with the stars by them were further west than our typical AAA service area. They both have partner hospitals or partnered with the main hospital in Fort Wayne, Parkview Hospital. So there's a couple of satellite offices in those counties. We decided to open those up for referrals as well at the request of Parkview Hospital. Each of those surrounding counties, by the way, has about 30 or 40,000 people in them. Okay, go ahead. Thank you. The impetus of hospital at home. People living with dementia and their caregivers experience such challenges with their discharge planning. We know that the healthcare systems and community-based organizations are needing support as well in discharging people with dementia. So we wanted to, work with those agencies and kind of bring the dementia care to one point following hospitalization and connect people through aging and in-home services. We are hoping to fill that gap in community resources when they're transitioning, and that's where we came up with the care transitions model that we were using. Next slide, please. So at the beginning of the program, we are hoping that Parkview Hospital, Easter Seals ARC with the IDD population, and our PACE program, we're going to provide the referrals necessary to meet our goal of 400 dyads. Next slide, please. So during that first year, referrals were coming in slower than what we had anticipated, much slower. The average number of referrals during that month, or the average number of referrals during the month for the first 12 months was under 7. Those were from those 3 referral partners solely. And we knew that there, obviously no way we're going to meet our goal of 400 dyads with numbers like that. We were hoping when we first started the program that we'd be granted access to the Epic, electronic health records or receive some help getting the diagnosis and what room numbers people were in, and that just stalled out, and we weren't able to get any traction with that. But in June of 23, so after our first year, we hosted a dementia summit for caregivers and professionals. And I think this was one of the turning points in the program. We started receiving lots of RSVPs for a dementia summit. We received 124 RSVPs, which was more than I could have expected at the time. Again, our challenges and barriers, were, initially the presentations that we were giving to the community and to these programs were just to the primary hospital network and Easter seals. And so we wanted to branch out from that a little bit. Our referral process was also limited to the referral sources. The only way we were accepting referrals at the time was through email. And we knew that we were going to have to make some changes again. So we started planning for growth. My supervisor had some ideas for growth. We took those very seriously. She had a thought of build it and they will come. So we just went forward. And so we identified and connected with lots of new referral sources. We connected with specialized teams within Parkview Hospital. We established new community referral sources. We reconnected with our previous referral sources. We knew that we'd have to stay in front of these people, possibly many times, to keep our name out there and let them know the good work we were doing. And so we, worked with our own internal Aging and Disability Resource Center. We reached out to home health care and palliative care providers. We made a concerted effort to go out into each one of those small counties of 30 or 40,000 people, hit those community hospitals and let them know about the program. We talked to crisis interventions teams, the VA, the Sheriff's Department. I met several times with the ADRC supervisors, knowing that they're a first point of contact for us and that we could identify people with dementia and their caregivers right with that first call, and we wanted to take advantage of that. We hired a couple more workers. We hired a health educator, an additional care coach, and an additional respite coach. We printed and really put out a lot of flyers as well during this time. Okay, so planning for growth. We're going to talk a little bit about how we got here, but we identified 10 sectors that we would like to work with. You can read those there, everything from psychiatric hospitals to skilled nursing facilities and those community and rural hospitals, adult day services, etc. And then each entity, after each entity, we discussed who do we want to target within that sector. So with the home health care and palliative programs, we knew that there were a lot of them, so we hit those hard. And again, as you can see on the graphic, that we hit about 45 different potential referral sources and let them know about our program. So we made some action steps. We wanted to use that RSVP list for the Dementia Summit. So we reached out to all those people regularly. We were sending out regular emails to them, letting them know about our program, letting them know that we were open to come out and meet with them. Again, we talked to our ADRC supervisors and staff. They implemented a tracking system so that the supervisors knew people with dementia that were coming in and their caregivers were referred to us if they were in the hospital or had an immediate recent hospital admission. And we continue to provide overview and referral training to all the Parkview Hospital teams who have direct patient contact. So within Parkview, I started, poking around, asking a lot of questions, and had my own health issues at the time, and my mom had health issues at the time. She had dementia, and I just started asking anyone and everyone I came across there, hey, do you ever work with people with dementia? Of course, they say yes. And then I asked them if they know about our program, if they ever need any extra help with discharging people with dementia. And I was able to meet with these different teams there: palliative care, occupational therapy, crisis intervention teams, hospice team, chaplaincy, emergency department social workers. So we really went into Parkview knowing that we wanted to touch everyone who has patient contact, direct patient contact. Next slide, please. We also provided alternatives to emailing. So we were thinking that that could be a barrier. So we, started putting on our referral forms. We'll accept fax referrals. Please fax them to this number. We ended up getting a lot of fax referrals. We also encouraged all the referral sources to call me. So I know they have challenging patients. I know that they, sometimes they're not sure if they would meet program criteria, or maybe they know just a little bit about hospital to home program. I told them, give me a phone call. Please call me. I'll talk you through it. If needed, I'll type up the referral form right then and there. I'll take a note. And, we were going to accept as many referrals as possible. And if not, I was able to take that time, do some education with the person who was wanting to make a referral, and maybe refer them to someone else that could help them better if they weren't a good match for the program. Also, if I received email referral forms, I responded immediately back, hey, we got your email. We'll be reaching out to the family as soon as possible. Getting the referrals sources is one thing, maintaining them is another. So we had some support staff help us send out regular ongoing emails with the referral form and with the hospital to home flyer attached. So we would send those out to 129 different people from those 45 sources. We included in those emails lots of success stories, participant quotes, just little things like, hey, our respite coach helped us so much. We don't know what we would have done without you. Thank you for helping us. My mom's doing better. We appreciate your help, kind of thing. So we're putting all that marketing right into those emails, which seemed to be helpful. We also did staff highlights where we have a great staff. We had great people. The boots on the ground were awesome. And we were able to highlight their experience and what they've been doing and how they help people. I also scheduled a 5-minute phone call with Parkview Hospital every month. I know they were very busy. Sometimes they took these phone calls and I'm sure their cameras were off and I'm sure they were walking through the hospital, but I got my 5 minutes in to, review the number of referrals we got from them, let them know how other referral sources were doing, and request feedback from them. Next slide, please. We also did a lot of referral appreciation. So that was another recruitment and retention feature. We provided handwritten thank you notes to the people that were providing referrals. So we try to do that with every new person that provided a referral. And then if, some people were providing multiple referrals. And so we really wanted to continue to thank them. And so we write, thank you. We really appreciate all the referrals. We also did some more conventional things like bringing cookies, donuts, chocolate deliveries. Of course, they love that. And when I did that, I would call someone like a point of contact there and say, hey, when is the most likely time I can see most of your team? And they would, tell me. So when I delivered it, then I could meet a lot of the team, tell them thank you, make it short, sweet. Thanks. You have any questions? Otherwise, I'm out. Okay, next referral, please. Next slide, please. Education presentations. This was a really pivotal moment, is that we had a great health educator. She went out into Fort Wayne and the surrounding counties and provided education to those counties regularly. Some of her topics are listed here. And she delivered presentations to more than 1,000 caregivers and professionals across our 9 counties. So that's a lot of good outreach. Here's a graph showing her work and my work and getting out and making these community contacts. So as you can see, as the community contacts increased over time, the referrals increased over time. So, we did a few contacts in July 22nd, but we didn't have many, or July 2022, but we didn't have many referrals. But as time went on, those health education contacts went up and our referrals followed. So it took some time for that to grab hold, but once it did, it was extremely helpful. And we also use that health educator to help out with screening our referrals. So we get a lot of referrals. She would screen them, help screen them. She would put maybe an hour a day to the side and call the families, touch base with them, try to schedule the intake with them. So that allowed our care coaches to not be so concerned with that part of the job and to go ahead and just work with the families and not worry so much about the recruitment and setting up the initial intakes. This is our graph indicating how many referrals we received per month. And you see that first year or almost year of time, we were not receiving many referrals at all. So once I see in like May of 23 is when we started advertising that we were going to have a dementia summit. And I think that helped get us some referrals, just knowing that, we're serious about this. We want to be a great community partner with you. We want to serve people with dementia. We welcome you to this dementia summit. And in June, I believe, was the summit. In July, we were transitioning a little bit, and we really started sending out those emails and trying to get more referrals and more points of contact. As we did that, our referrals just took off. We were providing good services. We were getting lots of contacts in the community. We kept thanking people. We kept thanking the referral sources, and as you can see, our referrals just took off. The reason why February is so low is that's when I stopped counting when we were initially set to give this presentation. So things really didn't drop off. We were probably at 45 or 50 referrals that month as well. Our referrals per source. So here at Aging and In-Home Services, those came from our Aged and Disabled Resource Center. Parkview has a couple of hospitals in Fort Wayne, the largest one being Parkview Regional, the smaller one being Parkview Randalia. So that's proportional and good information that they were making a lot of good referrals. And two things I want to point out is Cameron Hospital. That's a small community hospital about 45 miles from Fort Wayne. And that's a 20 or 25 bed hospital. And as of February, they had provided 65 referrals, which is a lot. There are 2 social workers there. We worked with them. We thanked them. We would talk to them, regularly on the phone. And it's still a good relationship. And we hope to work with them in the future. And then the other category. So those are, the rest of those, there are 45 referral sources. Here's 4. So that's the 41 referral sources. Some of them, provided only a couple referrals, some 10, some 5, but it helped us increase the total volume of referrals. We were converting probably close to, if not a little over 50% of our referrals. We were converting those into actual enrollments into the program. Next slide, please. With sustainability, we are lucky enough that we got to be able to be selected for the Guiding and Improved Dementia Experience model. So we're one of the few AAAs that will be spearheading guide here in just 2 weeks, I believe. Really, the hospital to home program has provided us the opportunity to be a leader in dementia care in Northeast Indiana. And we learned so much about care navigation services, establishing partners. We learned of so many partners out there that we can benefit from, providing them referrals. So it was a great partnership that way. We're going to capitalize on this success to provide the hospital to home services, to reach and provide dementia care services in Northeast Indiana through that guide program. Thank you for your time. If anyone has any questions, please let me know. And thank you very much.
Thanks, Todd. We'll move on to Susan now. Just pop your questions if you have them into the Q&A, and we will get to them at the end of the session.
Thank you, Sari. Good afternoon. Thank you, everyone, for your time today. I'm Susan Sprague. I'm VP at OCCK, which is a developmental disability organization in Kansas, serving people with any type of disability. The title of this presentation is Moving Beyond the Usual Partners and Embracing Adaptations. The event title hints at the message, Moving Beyond Assumptions and Embracing Adaptations. During this PowerPoint, I will expand upon why these words are appropriate when describing our Administration on Community Living grant at OCCK. Next slide, please. The work presented in this PowerPoint was made possible by a grant from the Administration on Community Living, Health and Human Services. Next slide, please. This is the OCCK Cognitive Care Navigator team. Cognitive Care Navigator is the title given to our care ecosystem direct support staff. You'll see Brooke, Michelle, and Kelly are OCCK's Cognitive Care Navigators. Our navigators even have either a human service degree, or we happen to have one credentialed physical therapy assistant. Our partners on this grant are Kansas University, Alzheimer's Disease and Research Center, Republic County Hospital, Neighbor to Neighbor, and Harvey Drug. Our Kansas University partners are also Cognitive Care Navigators. The Rural Hospital, Neighbor to Neighbor, and Harvey Drug were facilitators and referral pathways to the care ecosystem. Next slide, please. OCCK was created 54 years ago by a small group of parents that wanted access for employment and opportunities for people with intellectual and developmental disabilities. As the Occupational Center for Central Kansas outgrew its name, it was shortened to just OCCK. The mission: to provide opportunities for people with intellectual and developmental disabilities, or IDD. The organization has grown significantly over the intervening 50+ years and now serves people with developmental disabilities, physical disabilities, seniors needing home-based supports, people living with brain injury, kids with autism, and people living with dementia and their caregivers. Our staff has grown from a small group of parents, 13 to 365, but our mission has remained consistent over the years, serving people with any type of disability to live independently in their chosen home and community. Next slide, please. Prior to OCCK submitting and receiving the Administration on Community Living grant that I'm speaking of today, we had opportunities to participate and partner on ACO grant Reducing Disability in Alzheimer's Disease that was led and awarded to KU ADRC. And this was the start of partnerships and foundations that launched future opportunities and opportunities for collaborations here at OCCK. It's been my experience with these opportunities that awardees rarely stand alone. I know we haven't. It's growth and that networking that has been the foundation, and it builds partnerships and opportunities to expand. Next slide, please. The first 12 months post-grant award were spent refining our grant work plan, objectives, with the guidance and encouragement from the National Alzheimer's Dementia Resource Center, SARI, and the Administration on Community Living, as we developed a solid work plan and evaluation plan. That work plan creation process was challenging at times for me and our team at OCCK. However, looking back, I can see how it created a roadmap with clear goals, steps to achievement, and how to measure what was accomplished. This served as a springboard to our implementation, and it has been our touchstone to keep us on track. We planned for Zoom rooms or teleconnection as a bridge between the person living with dementia, their caregiver, to the care ecosystem or cognitive care navigation supports. Originally, we planned brick and mortar places to go, with a community-based facilitator that facilitated the connection or the referral to supports of the care ecosystem or the cognitive care navigators. What we ended up with are adaptation, were community-based care facilitators that became very good at networking within their community. This networking was the impetus that brought about growing our strongest grant partners and referral sources to the ecosystem. And that was faith-based organizations and privately small town-owned pharmacies. Privately small pharmacies. We anticipated strong partnerships with the health professional community. And this was one area that we needed to embrace adaptations, leave behind what we thought or anticipated as being true, and what ended up as actually true for us and this grant. Next slide, please. We chose the care ecosystem as our evidence-based model. Care ecosystem was created as a medical model. For purposes of this grant in OCCK, we adapted it to fit a rural or frontier community-based model, a model with a focus on intellectual developmental disability, formal and informal caregivers. We did this adaptation by embedding IDD-specific trainings, IDD-specific rural community adaptations, addressing formal versus informal caregivers, early detection of dementia in the IDD population, and those living alone. We had envisioned use of Zoom rooms for a variety of reasons, thinking it should work well for rural communities and lessen travel time. For OCCK, this vision did not transfer over to real life implementation. We continue to travel to the person living with dementia and their caregivers, often as the request of the caregiver. This in-person visit combined with phone call supports ended up being successful for participants. KU, Alzheimer's Disease and Research Center, was successful by combining phone calls and meeting with the person and caregiver at local doctor's offices, health offices. Our adaptations included not requiring a caregiver to be identified, and also not requiring a diagnosis as necessary to receive supports. We accepted referrals for people experiencing changes in behavior. Oftentimes, people would say they didn't have a diagnosis, but upon referral and conversation, we often found medications that were tied to managing dementia. Sometimes people don't know they have a diagnosis. They just know that they're experiencing change. Next slide, please. If you look at this timeline, you can see where we met up to barriers and we had to embrace adaptation. Notably, when an initial grant partner had significant life changes and left the grant completely. When our IDD peers did not participate as expected and completely dropped out of the grant. These barriers ended up promoting adaptations and opened up opportunities with faith-based and our pharmacy partners. Looking at the timeline, there were a lot of changes early on that we needed to pivot or adapt to. As we gained in our lessons learned, our connections shifted, and you'll begin to see in late 2023 and 2024 expanding partnerships, new partnerships, and a solid foundation for growth. Next slide, please. Sometimes the best ideas on paper just don't see the light of day. As our nation transitioned out of COVID and the isolation that often accompanied the pandemic, on paper and intellectually, it made great sense to focus on facilitated brick and mortar Zoom room spaces and this facilitated connection to the dementia cognitive care navigators. We needed to adapt. Zoom rooms never really took off. The community-based facilitator became a community network builder and a source of local trusted information and a warm handoff to the cognitive care navigator. If technology was used, it was facilitated by the community-based facilitator or navigator, and it was often initiated and demonstrated by that person as well. Next slide. We based some tasks on the expectation that the medical field would be our strongest partner. But due to many things, staffing, time constraints, existing treatment approaches, we learned that often, though always, medical professionals want the best for people and are great partners in general. This just was not, in our situation, a viable option for them to fully participate as a partner. So we adapted. We listened to those organizations that sought us out, that initiated interest and requested engagement from us and wanted continued conversations with us. They saw their role within what we were trying to do. And this is where we were able to, I'll use the word again, adapt, and that promoted this growth as we embraced those changes. Next slide, please. We expected to have a lot of people and caregivers within our IDD community. We're a 54-year IDD provider. This was surprisingly the least responsive population, equal to health professionals. IDD has a certain number of tasks they need to complete as part of what supports they're already providing. And a lot of those supports through day and residential services are already in place, kind of, sort of. Our cognitive care navigators encountered similar barriers to those that they experienced with health professionals and medical. Often folks were busy. Maybe they were short on staff or just a busyness to staff. They had tasks that they needed to do, and those tasks needed to take priority. And they had a sense that they already had a kind of a basic knowledge or a basic understanding about dementia. When we made outreach to other IDD providers, though there was initial interest, when the rubber met the road, they simply could not absorb what they perceived to be additional tasks and additional responsibilities. The navigator shifted to conversations about noticing change, ruling out change tied to a physical or environmental something. The focus between navigators and IDD shifted to conversation, teaching on the fly, training, teaching on the fly with direct support or paid caregivers in the world of IDD. Next slide. Primary care docs they're busy. Their time is often limited available or free time. And so we adapted from expecting action to the cognitive care navigators providing supports within the community and wrapping those supports around the person. Next slide. Who we thought, would be our lead partners, IDD and hospitals or medical, were often, like I've said, like I've shared, we're busy. Others, maybe ADRCs, law enforcement, that type of support. Sometimes it was too late. And then finally, on target with, for us, our Neighbor to Neighbor. This is a Catholic-based charitable service organization. And again, that's small town, locally run pharmacy and adult protective services. Often in the too late, sorry about that. I just wanted to say one more thing on the too late. In the too late category, what we learned was that often caregivers weren't calling until it was maybe a crisis or they felt a lot of crisis. And at that point, those slower moving response systems, it just wasn't acting quickly enough to respond at that moment. Next slide. Plans change, keep focused and roll with it. There's a community who's in need of you, find them, listen to them, create for them. If the plan isn't working for your targeted population, change the plan. If your great idea didn't work, see if there's a way that it could work. Your team will be successful if given the opportunity to try. Encouragement to keep going, and the foundation of good tools. Next slide. Thank you so much. I appreciate your time and I appreciate your listening to what I had to say today.
Thank you so much, Susan and Todd, for your excellent presentations. Patrick, we can go to the next slide. So we will move to questions in just a minute. I just want to post up here how you can be alerted to other ADPI opportunities. You can look for notifications in grants.gov. If you have questions for us at the National Alzheimer's and Dementia Resource Center, please send those to NADRC-webinars@rti.org. At this time, we will move into questions. You can continue entering questions into the Q&A pod throughout the session that we have right now. And the first question came in right when you started talking, Todd, if you could address this. And then I will address it a variation of it to Susan after you're done. Can you talk about any staffing or communication challenges you faced when you extended your program to the Western counties and how you
Yes.
navigated any challenges?
Okay, thanks, Sarah. Yeah, so the main challenge was the distance. So the drive time to get out to do the intake, and then if they wanted the respite component, that was a respite coach driving, over an hour to do a few hours of respite and an hour back. So it was a big chunk of time. Another challenge is that wasn't our AAA. So, that wasn't our AAA area. So we had to, have their information at the ready and know their program so we could make good referrals. And, sometimes, it was a lot, but we didn't get a lot of referrals from that agent, those two Western counties either. But all in all, it's a good thing. Our hospital partner asked us to do it. It was an easy yes. We'll give it a try.
Great, thank you. Susan, can you talk a little bit about the travel issue for those who you work with in Kansas, since you kind of address this, it's your everyday life?
We do. Well, for us, it kind of starts with a commitment. Our commitment is there to rural and frontier communities and small communities, and just the philosophical base that people live independently where they choose to live and how to support that happening. So it's maybe not the best answer in the world, but travels just tends to be, and it's challenging. Windshield time isn't necessarily when you're sitting down on the couch having providing support to caregivers, but it seems to be necessary in order to reach people that you would wish to reach.
Yeah. Well, you did try the other way and realized that you had to be in person. So
Yeah, true.
Todd, can you talk a little bit more about the role of the respite coach in the hospital to home model and what they do, what their background is?
Sure. So we've had three respite coaches that provided the vast majority of the respite hours. The respite coaches did no hands-on care at all. So it's housekeeping, meal prep, companionship, activities. All three of them had a lot of good experience too within assisted livings and nursing facilities, and especially with people living with dementia. So two of them had great experience with that. Our other respite coach worked at an adult day service for years. So she could really engage, and she did a good job with just connecting with people with dementia and providing excellent activities for them to do and really making it person-centered. We'd ask the people living with dementia and their caregivers, what activities do you think they would enjoy doing? What do you think they would like to do? What type of music? What type of crafts? Or do they want to look through books about their favorite hobby that they had? Listen to music from when they were in their 20s or 30s. So we used all those methods that we learned in other programs to really connect with them. And the most important, or one of the most important things, is that they provided an excellent feedback loop. So, we checked in with the respite coaches every day. How did your visit go with them? What did you see? What did you learn? How can, what do we need to be doing as care coaches back in the office? It worked great that way. It really did. We also met on Monday mornings with the respite coach and all the care coaches. We'd meet bright and early and set our schedules, talk about what we wanted to get accomplished that week, get them down on the schedule, and move on.
Great, thank you. So we'll move to another question. Susan, can you talk a little bit about the navigator role at OCCK and what the background is of your navigators and how you train them?
So the navigators, it's fairly comprehensive training. The care ecosystem has an excellent training that's provided, and all of the navigators went through that training and successfully completed that training. There's training specific to and the tools that were used, so specific to early detection, specifically early detection in intellectual developmental disability, those types of things. Part of what we did with our partner KU, they really were excellent on putting together a being proactive, which was a very a good training specific to caregivers, formal, informal, working with people living with intellectual or developmental disabilities, and that early detection of Alzheimer's or related dementias.
Great, thank you. And Todd, can you touch on the role of the care coaches in the case of AIHS and how what their background was and how they were trained?
Sure. So their backgrounds were varied a little bit. One that was employed for a while and not through the whole grant was a nurse who made home visits at her previous job. And so she was able to really connect with people and knew the medical aspect and could really help with the readmission prevention part of the program. And our other main care coach, she was trained in aging brain care and provided and learned through an ADPI program. Thank you. That was in the state of Indiana and learned the aging brain care models. And so we learned a lot from IU and the aging brain care models. And she was also an options counselor for our ADRC, so she knew how to screen people for waiver and home delivered meals and such. So sometimes she would really just get a head start on that right from the time she met them. So a variety of things, and we worked good together as a team.
So it sounds like for both programs, there wasn't any specific licensure or degree. It was more the background, willingness to learn, completing the training, any other secret sauce for, the hiring of the people who are the boots on the ground workers?
Todd?
I love those soft skills of just being able to connect with someone, and you can learn that through an interview. How quickly do you connect with them? Or, is their demeanor affable and kind and an energy level that's going to match someone with dementia? Like, are they going to go in with the right communication skills? Are they going to go in with the ability and the energy to help with agitation, those kinds of things. So yeah, I look for those soft skills.
Great. Susan, anything to add?
I agree with what Todd said. I think the energy level, you can see it on a person's face. So that's something important.
Great, thank you. So Todd, you mentioned a 50% enrollment rate from referrals. Did you collect any data to determine why the other 50% were not interested in hospital to home?
Yeah, so we in our referral tracker, if they did not want the program, we would move them to a different spreadsheet and mark what happened. A lot of times, people weren't responsive to our phone calls, and maybe they didn't recognize our caller ID. Sometimes some other reasons were they moved into a short-term rehab and ended up in long-term care. Some people were, just hesitant of someone else coming in, or thought, oh, my mom or my spouse is so agitated, we cannot bring anyone into the home. So with those clients that thought that the program wasn't good for them, but they still needed help, we helped them. We would try to fit them with another program that would benefit the caregiver and people living with dementia.
And Susan, how about for care ecosystem at OCCK, when you had people who did not want to enroll, was there a specific reason or a set of reasons that you caught on to?
You know, I don't know that there was a specific set of reasons. I touched on a few that are specific to IDD and formal caregivers or paid caregivers, just having a lot to accomplish in their workday. Sometimes people didn't want to enroll in care ecosystem supports, but they might have spent an hour to an hour and a half on an initial conversation. So, I think we always try to say, listen first, and that will guide you. So I think that would probably be how I would answer that, Sari.
Great, thank you. Okay, so one of the last questions is more about preparing ahead of time with palliative care agencies and connecting with any. Did you have any connections with palliative care through your programs, through your ADPI programs, that helped your participants kind of prepare for the future?
We did. I loved working with palliative care. They were one of our better referral sources, and I had no idea they would be, but we found some palliative workers that were going out and meeting people in the hospital or in other acute care settings, and they used us as a resource. I pitched it to them. We can help you along with this. Let's help these caregivers together. And I received a lot of referrals from them. And the flip side of that was, when you're working with the families, they're going to need help after you leave, and you want to, sometimes refer them to hospice. And sometimes that was hard for them to hear. And the agencies around here that do palliative also do hospice, and they can do the assessments at the same time. So that was a good way to connect our participants with long-term services.
Great. Susan, did you have anything similar or something to think about for the future, maybe?
Probably something to think about for the future. Yeah. No, Todd, I appreciate what you said. Our experience was limited. So something to think about for the future.
Yeah. Well, that's great. Well, we have reached the end of our time together. So I want to thank you both, Todd and Susan, again, for your time with us and your presentations, and for imparting such great information on to our participants. And thank you to everyone who joined us today. Our next webinar is on July 9th, where we will present on Lewy body dementia, navigating diagnosis, care strategies, and essential supports. So keep an eye out on your email for the link to register for that webinar, and we hope to see you there. And with that, we hope you all have a wonderful afternoon, and thank you everyone again for joining.